States. So this is like about 5 to 6 deaths per million, at this area. And then these are the 3 countries that are listed here: Taiwan, South Korea, and New Zealand. And those, managed to keep death rates pretty low early on in the pandemic. So how did they accomplish that? So Taiwan, they closed their borders very quickly because they're close neighbors to China. They used technology in different ways, like tracking people to make sure they stayed in quarantine, which wouldn't work here, but that's something that they were doing. And then they had a really centralized government response. And that's something that is a challenge for us because of all the states and the fact that states can have different regulations from each other here in the United States. So South Korea, they had extremely strong testing, tracing, and quarantining system. This is just the basics of a pandemic response, and they were able to do that right away. And the reason that both of these countries were so well prepared was because they had experienced either the SARS epidemic or the MERS epidemic. So because of that, they had put the infrastructure and the funding in place to say, hey, we're not gonna be unprepared if this were to happen again. Another kind of success story was New Zealand. They were very quick to shut down the country once they were able to see that first case come in. It just took a few weeks. They had shut down the country. And that's hard to do. It's hard to tell everybody to just stay at home and that's what you have to do. But the Prime Minister was so proactive, and she got on Facebook Live and answered people's questions, and her toddler would interrupt her. So she was just very clear and direct in her communication with her citizens, and that very much impacted their ability to have cooperation by their citizens. And then finally, social supports. They're telling people to stay home, and they're also giving that protection that, you're safe, your home is safe. We're not going to allow you to become homeless because you're losing your job because of the lockdown. So all of those things really helped to protect their populations early on.
So we quickly learned that social distancing was one of the mainstays to limit spread of infection. The number 6 feet seemed to be agreed upon as a critical distance worldwide. What was the justification of masking and 6 feet distancing, and did this really make sense?
So to answer that question, you have to remember what are the rules of transmissibility. And the rules of transmissibility is that you have to know how prevalent the disease is, and how long were you exposed to, and how close were you to the exposure. So basically, length and distance. So that's how that whole thing came along. So if you all know this, but SARS-CoV-2 is an RNA virus, and it's respiratory borne. So initially, the thought was it's spread by respiratory droplets. So they're bigger particles and shorter distance. And later on, we learned that it's actually airborne as well. So airborne means that it's smaller particles and longer distance, and it stays in the air for a long period of time. And the other thing we learned was initially, we did not know that this was an important finding, because we did not know that 1/3 of the patients were asymptomatic. And of those asymptomatic, 60% had SARS-CoV-2 infections, and they could spread it. And 35 of those were pre-symptomatic individuals, and 24% of those never developed symptoms. So that's when this finding actually transformed our approach to the infection and wearing masks. So that's when the mask mandate came along.
So as Dr. Khadir mentioned, we had our masking. We kind of came late in the game with masking. It was April by the time that we finally got a recommendation that we should be masking. There's a chance there's asymptomatic transmission. And one of the key reasons, was that they were afraid that, or just the fact that there was a big shortage of PPE for healthcare providers. So this was just a reminder, that women in our community were sewing masks for healthcare providers. So that's something we hopefully never want to happen again, right? We want to make sure that our PPE stocks are high so that we never have to sew masks for our healthcare providers, let alone the people in our communities. And like the 6 feet rule, that was, looking back at how that was developed, it was kind of based on studies all the way back in the 1940s, where people would take pictures and see how far the visible droplets went. So, it was a little bit based on things that weren't necessarily COVID, and we'll talk about that in the next slide as well. And then we also had the hand and surface hygiene, right? People were wiping down their groceries at one point in the beginning of the pandemic. So things have shifted since then. We want to think, or we realize that we need to think beyond 6 feet, right? Multiple factors affect COVID-19 transmission risk because it's not simply transmitted by droplets, it's also in the air. The air quality has changed. So here, this was a study from the British Medical Journal, published in August 2020, and they basically did a critique of the 6 feet rule or the 1 to 2 meter rule, and they said, well, actually, it's multiple factors that go into this. Whether or not you're indoors or outdoors, whether you're talking loudly or you're silent, how long the contact is, how many people are in the area, whether or not you're wearing face coverings. And then you might notice that there's a couple columns that are very high risk, So what is it that is a really high risk situation? I've also underlined it. Can anyone say what would be a high risk, one of the most high risk factors? Ventilation, right? Poor ventilation. And was that something that we really talked about much early on in the pandemic? Is it something that we talk about a lot right now? Okay, that's good if you are. I feel like that's an area that we really can continue to improve upon because that's relevant for the common, the flu, any other respiratory illness. If you're in a small confined space with a lot of people, viruses are going to spread, but something as simple as opening a window can make such a big difference. So I really encourage you all, in your homes or in your offices or our jamaats, think about where we can improve our ventilation, and there's so many resources available on the CDC website. I'm not an expert in ventilation, but there's so many resources that I think all of us can see where we can make those improvements to improve the air quality indoors.
So Dr. Khadir, working in the ICU, you've seen some of those most critical cases of COVID-19. You showed us one case. And you also mentioned that the majority of these cases that we see are asymptomatic or mild. I think we've all seen that this has led society in general to take less and less seriously this virus and to lack respect for the infectious spread and the vaccine, especially in the US. And that's allowed the virus to continue to wreak havoc. How are the clinical features of COVID-19 affecting morbidity and mortality in US communities?
So in the beginning of the pandemic, this was the paper that came out from China. And they told us that of the 72,000 cases they had in Wuhan, basically, they said that 80% of them were mild to moderate disease. And 20% ended up in the inpatient setting, so they had severe disease, with a case fatality rate of 2.3%. Now, look at Omicron right now, the case fatality rate is only 0.6%. And what they told us that the ICU mortality was about 20 to 40%. But we all know, people who have worked in the ICU, that once a COVID patient gets intubated in cytokine problems, their mortality goes up to 50 to 70%. And that's the reality of it. So The amazing part about this disease that it comes in 2 stages. One is that 0 to 5 days. Like, you get this upper respiratory infection kind of thing, like, a common cold, and you get over it, okay, fine, you got that mild to moderate disease, 80% or 90% of people do that. But then there are about 10 to 20% of patients who go through that second stage, between the 7 and the 20 days, where you get this surge of inflammation in the body and coagulopathy with it. So that's what led to the severe manifestation of COVID-19, which affected every single organ of the body, you name it. We saw that in Jeopardy yesterday. We saw images of COVID-19 and affected every single organ. We saw the brain, we saw the kidneys, we saw every single one of them got affected by it. And the patients that were much more vulnerable were elderly and people with diabetes and obesity. And now we know that unvaccinated people are much more higher risk. So COVID comes in, the post-COVID syndrome comes in 2 flavors, right? So one is people who got severe disease and they got residual organ damage from it, like lung disease, renal disease, patient ended up on dialysis, oxygen, whatever that is. So that's the first kind. And now we're hearing about long COVID. So these are people who were at home, they did not get any severe disease, and 10 to 30% of COVID-19 patients who ended up with the mild to moderate disease end up with this long COVID syndrome. This we don't know too much about. The pathogenesis is not explained by the disease itself, and we're still learning about it. What are some of the manifestations of long COVID? Are extreme fatigue, shortness of breath, dysautonomia, temperature dysregulation, and this brain fog thing, which is like you're never sharp anymore. Like, it's going on for almost a year. And like their thinking is not as sharp as it used to be. So, and we're still learning about it, and we don't even know where it's going to end up.
There's the obvious challenges with the individual, but how does this look like in a macro perspective across society? So based on recent data that came out of the CDC, approximately 1 in 5 people have some sort of incident condition that could have been attributable to a prior COVID illness. So if you take the 85 million people who've gotten COVID in the United States, divided by 5, that's approximately 17 million people who have had or currently have a chronic long-term illness because of their COVID infection. In addition, long COVID is now accepted as a disability under the Americans with Disabilities Act. And the Solve Long COVID initiative has estimated that approximately 7 million people cannot go back to their pre-infection functionality. So these are 7 million people in America that basically have a new disability. In addition, there are economic implications as well. It's been estimated that 1 million people are out of the workforce at any given time because of long COVID conditions. And then finally, based on some of the costs from similar conditions like chronic fatigue syndrome, and this was all from an economist who published in JAMA just right now in May about the cost of long COVID. They cited that there could be up to $9,000 in costs per patient per year to manage their long COVID. And that's the cost of the individual, right, of the patient, but this is a burden on our entire health system. There have been, and it's changed our entire health system. As of February 2022, Becker's Hospital Review found that over 66 health systems had started some sort of a post-COVID clinic, right? So that's huge. That is a radical shift in our healthcare system, and we're just getting started. I do want to make one point, if you don't mind. It's that this just shows that it's not, it is imperative that we continue to try to stop COVID infection, because we're essentially saying that it's okay for 1 in 5 people to get a new chronic illness. So that's just my little spiel in terms of the fact that we're not as worried about severe disease and mortality doesn't mean that there aren't long-term consequences from COVID infection.
Dr. Khadir, COVID treatment has been a hot topic since the beginning of the pandemic, leading to significantly different approaches around the world. We've seen conflicts between scientists, different countries, different politicians. Can you walk us through our initial treatment approaches and how they progressed?
That's a tough one. Who can tell me what movie this is? There you go. That's exactly how it was. It was the perfect storm. This was not easy. And we were heavily focused on severe disease. So if you look at an RNA virus, you see that what happens is you have this spike protein, it attaches to a protein in your body, it gets engulfed by the cell, and then it replicates and makes protein and then makes more viruses and comes out onto the cell. And that's what an RNA virus does. So what people did is they tried antibodies to block these proteins. We tried hydroxychloroquine and chloroquine as well, which increases liposomal pH in the cytoplasm, so you don't get this process of endocytosis. We tried blocking the protein making by HIV medications. This was the only FDA-approved antiviral. We'll talk about that a little bit more. And then these were the steroids and the interleukin-6 and stuff like that. So we tried all that stuff. But there was no clinical trials. So we depended on what? Social media. And the information that was coming along was drastic amount of information. It was very hard to sift through what was good and what was bad. So in March of this year, of 2020 actually, sorry. In March of 2020, WHO came up with the Solidarity Trial, which was the biggest trial in the whole world. Actually, it was about 14,000 patients, 60 countries, 52 hospitals, and about 2,000 researchers were involved in this. And what they did was they studied these drugs, the remdesivir, the chloroquine, the hydroxychloroquine, the HIV medication, interferon beta, all these they studied in hospitalized patients. And what did they see? None of these drugs were effective. So what are we doing now for hospitalized patients? Actually, when they come to the ICU and they're on the ventilator, there's not much that works. We all know that. But what we do know is that if you treat them early a little bit, and you get them early a little bit in the severe phase, though they're in the hospital, they're hypoxic a little bit, you could do remdesivir, which the data is not too clear, but I still feel that there aren't much better and clearer data that is showing that if it's used early, that it does work. There's monoclonal antibodies that we know about, and there's convalescent plasma as well that blocks the targeting, that initial getting the cell, the virus into the cell, just preventing the virus to get into the cell, so you don't get that inflammatory response. So once you get that inflammatory response, we're doing dexamethasone. This was a big trial, the recovery trial, if you guys all remember. That came out in July of 2020. That was from the British Medical Journal, where they said dexamethasone at 6 milligrams per day for 10 days works well and decreases mortality. But what did we do? That we started using it in patients who were not even hypoxic. And actually, people started doing this as an outpatient. And clearly the data, if you read it properly, the recovery trial said it's actually harmful to give steroids when patients are not hypoxic. But that's what ends up happening. And these are the interleukin-6, which we do it at the end. And of course, the adjunctive therapeutics, which is the anticoagulation, which came out. And as you saw, that when you get this cytokine release syndrome, you get this thrombotic effect, and we use anticoagulation to prevent that. So that's what we're doing right now.
So social media has allowed us to disperse information in a quick and easy manner. We've seen an abundance of social media outlets, including Instagram, Facebook, even TikTok that I've learned. What? Afwa committees, yes. We have plenty of those. But we have seen that this is a double-edged sword. So Zainab, can you expound on what the country did well or not in our social media battle?
Absolutely. So, there's a saying that goes, what's 10 times more faster at spreading than the coronavirus and 3 times more deadly? WhatsApp forward. Right? And we saw yesterday in the Medical Jeopardy that we had crazy things being shared, influential people giving their own 2 cents, who'd never been to medical school or have a public health background. So we were dealing with this influx, and the WHO actually named this infodemic. So this is the overabundance of information, whether it be true or true or not true, that comes alongside a pandemic. And so, social media was a key component of this. And different social media companies, what they do to make it more addicting for people is that they create an algorithm that creates an echo chamber. Things that people like, they just continue to show that same thing to them again and again. So if you're liking misinformation and sharing misinformation, you're going to get more misinformation. And so the social media companies did try. They allowed people to, this is an example of you can report a tweet if you think it has misinformation. And YouTube kind of tagged any videos that had anything to do with COVID and said, you can go to the CDC or you could go to the WHO for more information about COVID. That's great. These are great steps, but misinformation is happening faster than we can get rid of it. It's a industry actually, it's a business. So they're gonna continue going, and we're gonna have to do something about it, right? So how can we fight misinformation if we can't stop it? Well, similar to a virus, I personally believe we can vaccinate against misinformation. And how would we do that? So that would be the second one, which is promoting health and media literacy. The main way to do this is by teaching people how to critically assess health information that they may come across either through WhatsApp or on the news or just through the grapevine. So what they can do is say, well, is this current information? Is this credible? What are their credentials? And that can really help them to say, this forward, it doesn't even have a source. I'm just gonna let this go. I'm not gonna forward it because I'm not sure if this is true. But if they have questions, the next step that they can take is talk to a trusted messenger. And throughout the pandemic, and most recently a Kaiser Family Foundation survey in April found that you all, healthcare providers, doctors, their child's pediatrician are some of the most, or are the most trusted people when it comes to information about the COVID-19 vaccine, for example. So you are trusted messengers for all your patients, and even if we're not clinicians here, we are trusted messengers, and we can share trusted information about COVID-19 to fight the infodemic. So how does this all look in practice? So I was involved in a project with a county health department in New York, and they actually worked with community-based organizations. They recruited trusted messengers from different community groups, and we worked with them, we interviewed them, and figured out what the needs were of their communities, and created a tailored, culturally relevant curriculum for their community members that included a lot of these topics, finding trusted health information online, asking questions to your healthcare provider, just basics about COVID spread and vaccines, and then also connecting them, to resources health information resources or healthcare resources in their community.
So, Zainab, in one word, vaccines. Let's go.
Okay, so vaccines, you know, a lot of the things I've been talking about are very doom and gloom. I'm here to say vaccines are awesome. This was a win, yes, yay! This was a win in our pandemic response. This was our moonshot. You know, JFK said, let's go to the moon, and we were able to, with warp speed, get these vaccines much faster than we would have you know, in other times. You know, a process that could take up to 15 years or more, we were able to accomplish in less than a year, which is really incredible. So how were we able to do this? The mRNA technology was ready to go. There was existing technology and knowledge available, and we were able to, you know, develop that, use the mRNA and get that vaccine ready. There was a hyper focus on this specific goal. And importantly, the government sent financial support and raw materials to the companies or the organizations that had the brain power but maybe didn't have the financial resources to get this kind of a thing done. And then also importantly, you know, there weren't cut corners. They didn't skip steps. As you can see, it kind of condensed things. Things happened at the same time. But you know, all of the players involved moved at the speed of science, which means they didn't you know, base their decisions on political pressure, but rather, what does the science say? You know, is this really effective? Is this really safe? And that's how they moved forward. Now the caveat I have to say is that we still don't have vaccines for our youngest kids, and so, you know, this is still a process that's going on, but this is a huge win, and in fact, the Commonwealth Fund estimated that just by November 2021, over 1 million deaths were prevented by the COVID-19 vaccines. So again, extremely big win during our pandemic response.
So, as Zainab said, this was a scientific breakthrough, actually. You all remember the November data, right, that came out in the New England Journal of Medicine with Pfizer and Moderna vaccine. And double-blinded, like, you know, controlled trials, 95% effectiveness, 94% effectiveness. I mean, can't get any better than that, right? So, but then there was always a skeptic, oh my God, it was like, you know, in a double controlled trial, this, that, how is it gonna fare in real world? So Israel actually did mass vaccination in their country. And this is what they published in Lancet in May of 2021 after they've like vaccinated 70 or 80% of their country. And what they said is exactly what the paper said actually, that it prevented SARS-CoV-2 infection by 95%. It prevented asymptomatic SARS-CoV-2 infection by 91%. Symptomatic COVID went down by 97%. COVID-related death, 97.5%. And COVID-related death, 97%. These are staggering numbers, you know? Exactly, COVID should be gone. You should say COVID goodbye, right? Basically, that's what you should say. But,
I'm always here to give the bad news, right? Yeah, so basically, you know, this is the cases that we were having in the US. As you can see, we did have a bit of a drop around the time that vaccines were rolled out, end of November or end of 2020, beginning of 2021. But then, you know, later on into 2021, we saw the emergence of the Delta variant. We saw a wave subsequent to that. Then between the end of 2021 and beginning of 2022, we had the Omicron variant, very dramatic rise in cases. It was from that. And then, you know, we had another dip, and then most recently the BA.2 variant has arisen, and that's kind of where we are right now.
so as Zainab mentioned, there was another variant. So what happened? So between May and September of 2021, so we got the Delta variant, which was detected in more than 160 countries. Transmissibility was greater than the Alpha variant, and the viral loads were more than 1,000 times more than the Alpha variant. But the key to this was the vaccine was still very active in vitro against Delta. But we were not fast enough in rolling out the vaccination. So what did they see? So again, when in Israel, because they had already done mass vaccination, and what they saw is that in Delta variant, they got their elderly people dying more. So then they measured the levels of what the immunity was. And what they saw is that in all these graphs, you see that it's all coming down. This is in all age groups, the immunity started waning down by 6 months. So that's exactly what happened. It was a waning immunity. And of course, we totally forgot about, COVID, so we started partying as well. And the crowdedness and everything that was going on at the same time between May and September. So that's what happened in between May and September. So then what came along? Booster number 1, right? So before I tell you about booster number 1, before I present the data about booster number 1, I want to tell you that WHO came under great scrutiny because most of the continents, most of the continents had already rolled out about 50 to 60% of their population had gotten vaccinated, except Africa, less than 7% vaccination status. So before you're giving booster to countries where there is already 60%, they did not do that. So we'll talk about that later on. But this is the booster data. The booster data showed that the vaccine was super effective. Again, because we know that it works in vitro. So again, after giving the booster vaccine, after 7 days, the effectiveness is exactly the same as the Alpha variant, 95%, 96%, 81% effective in reducing COVID-related death and hospitalization. Great data, right? But then, what did we get? Omicron. Where did it start? The origin of Omicron? Africa, right? So coincidence? Unlikely, right? Because less than 7% vaccination status. So you see that the difference between Delta and Omicron, 50 plus mutations in the spike protein. And Omicron, as you guys all know, the South African data showed that it's much more transmissible. 5% of patients needed hospitalization, 6% death only compared to 24% in Delta and Alpha variant. So definitely less virulent, but much more transmissible. But the problem now is it's evading the immunity because the spike protein has dramatically changed. So what happens is that you have an antibody that was created by the vaccination, and now it's falling off. It's not being able to detect the spike protein, and it's going through. And that's why you're getting the disease despite being vaccinated. And the problem is that it shows 3-fold greater reinfection rate. So if you get Omicron, that does not mean you're done. You can get it over and over and over again. So, what's the data on vaccination on Omicron? So, I'm going to focus on Pfizer because we don't have AstraZeneca over here. This was a New England Journal paper that came out recently, I think in May or June of this year, where if you look at this is the Delta bar, and this is the Omicron bar, okay? And the Omicron and the further ones, the BA1, BA2 that are coming along. So what you see over here is after you get the primary series, 2 doses later and 2 to 4 weeks later, the immunity is up to 65%, right? But 6 months later, although the immunity is waning in Delta at 62%, in Omicron it's going down to 8%, right? And if you boost it again, 2 to 4 weeks later, you get it back as where it was in the first, at level 67%. So if I'm a patient who is elderly, who is vulnerable to getting severe disease, I take my odds, right? And the odds are 67% is better than 8% and not getting infection. So second booster right now is recommended for elderly above 50, immunocompromised patients, people at severe high-risk disease who would develop severe disease. So at risk for getting severe disease. So that's what it's indicated for at this time. So where are we at with therapeutics now? So we talked a lot about vaccines, and people who cannot get vaccination for whatever reason, they have like an allergy and they have a contraindication. We have a monoclonal antibody which is called EvoShield, which you have to take every 6 months. This is for pre-exposure prophylaxis. If you are exposed, we have some monoclonal antibodies, but none of them that work against the Omicron variant. If you are positive, if you have a mild to moderate illness and you are at high risk of getting severe disease. Oh, we're going to take a break for Shahsab. No. Not yet? Okay, we're back. Slides? Slides? Hold on. Let me finish, and then she has some thoughts as well. Then we'll finish, and then we'll start questions. I'm sure there's a bunch. So it's okay. So what I was talking about was where we at with therapeutics right now, right? So we have pre-exposure prophylaxis. We have talked about. There's two things. There's a vaccination, and there's this EvoShield, which we use it for people who cannot get vaccinated, and you have to get it every 6 months. For people who get mild to moderate disease, who get COVID, and are high risk for getting severe disease, we have. Initially, remember I told you we were very focused on inpatient and severe disease, but now we have things for mild and moderate disease as well. So we have this monoclonal antibody. I'm not going to even pronounce it because I don't know how to pronounce these ones. So there's this bebtelovimab, and that's the only one that works against the Omicron variant. But we have antivirals as well, oral antivirals now. We have Paxlovid, which showed actually 90% reduction in hospitalization and death for people who get severe disease, who are at risk for getting severe disease. It is a protease inhibitor. Works like, it's like, when I showed you the first slide about the slide about the mechanism of actions where we were using HIV medication. This is exactly where it works, and it prevents protein synthesis. The only problem with this is it has a lot of drug-drug interactions. Okay, so you have to be very careful with, and as you all know, our people with at risk are people who take a lot of medications. So there is a lot of drug-drug interaction. This one does not have much drug-drug interaction. It is a polymerase inhibitor, but it's only 30% effective. It's called molnupiravir. And remdesivir actually showed, the data showed if you do use it in mild to moderate disease for first 3 days, actually works well, but you have to be hospitalized and you have to do it IV. That's the only way. And that's where we are with therapeutics right now.
Okay, so clearly we need the boosters, right? Omicron is evading our immunity. So where are we with vaccines right now? In the United States, only 2 out of 3 people are fully vaccinated in general, just the 2 series dose or the 1 Johnson & Johnson. And of those 67%, only 50% have received their first booster dose. So that's a pretty low booster rate among those that are fully vaccinated. And again, we don't have vaccines available for our youngest kiddos yet. So why is this happening? Why aren't people getting boosted if they've even gotten their full initial vaccine series? So the Kaiser Family Foundation in April did a survey to ask why people weren't getting boosted. And the first reason was people feel like they already have protection, right? A lot of people have already gotten COVID, or they have already gotten they had their initial shots, and they think that they have protection, which, we know that that's not true based on the data, and that's a place where all of us can inform our patients and correct that information. The next most common reason is that they just don't want to get it. And the last, the last reason is that they don't think they're effective. And that's because they see that people have been fully vaccinated, or maybe they themselves were fully vaccinated and they got COVID, right? But we know that the vaccine was never meant to prevent infection, rather severe disease and death, right? So that's another area where we can provide that education and correct that information. So let's go back to the just don't want to get it, right? What do you do about that? Well, that's indicative of, I think, probably one of the biggest problems we have with the pandemic response today, which is that we're just kind of tired of it. We're tired of COVID. It's pandemic fatigue. And I think that's a question that we can ask ourselves as individuals and also as a society. How much of what we're doing or choosing not to do is based on the fact that we kind of just wish COVID was over versus the reality of what COVID actually looks like right now. And just to point, if one thing that does work for people who don't want to do it, a lot of them do end up doing it when they are required to do it. So vaccine mandates do work in a lot of cases, just like seatbelt laws work, right? We don't want to wear our seatbelt, but we do because it's the law. So that is a strategy. A strategy that you can use in your practice is using informed refusal. So if somebody, you say, hey, well, I see that you're due for your booster. Can you tell me a little more about why you haven't received it yet? Okay, that's a good concern. Can I give you more information about that? Okay, yeah, all right, well, let me know if in a few days if you'd like to make that appointment and we can get you scheduled. So just having that exchange can potentially really increase that booster receptiveness, because we don't want to call people vaccine hesitant, rather vaccine inquisitive, right? They're still trying to figure it out and make that decision.
So on March 11th, the WHO declared COVID-19 a worldwide pandemic. That was 458 days ago. The US has spent $4 trillion on this pandemic in several ways. So Zainab, do we have control of this virus or not?
I'm having trouble with the clicker. Oh, there you go. Yeah. So do we have control? I'm sorry to say we do not. The state of COVID today, as you can see on the left, that's the CDC COVID-19 community transmission map. And these maps are all available, the COVID data tracker on the CDC website. Based on the case rates and test percent positivity, you can see that a majority of the United States right now is at a high transmission level, based on data from May 30th to June 7th, 2022. And then on the right side, you can see the COVID-19 community levels. So that's actually the community-facing, like layperson-facing map. The left side is more for healthcare providers, such as yourself. So the right map, you can see it's based on cases per 100,000 people, new COVID-19 admissions, and percent inpatient beds occupied by COVID patients. So, as the map gets more and more red on the left, you're gonna start seeing more and more yellow and orange on the right. And the right side, the East Coast right now is having some of those oranges, the North, Midwest, and also the West Coast. So that's the orange is when the CDC starts to say, let's bring back those indoor mask recommendations because we're seeing this impact on the healthcare system with the admissions and hospital beds.
So what I wanted to talk about is how do we get rid of a pandemic? There's 3 ways to get rid of a pandemic, right? So either you completely eradicate it, means that basically you wipe it out of the face of the earth and you don't need to use any active measures anymore. Or you eliminate it, where you have to use active measures to make sure that the disease is not coming in. And in the last 100 years, in the US, we have been able to completely eradicate smallpox, which we don't even get vaccinated about it and we don't know anything about it anymore. But we have eliminated polio and measles as well, right? So we can learn from that. How did they do that? So for smallpox, everybody got vaccinated and it's contact transmission. So you can watch somebody getting smallpox and you will just contain them and it's easy to contain. Polio, we're still vaccinating everybody and it's oral fecal transmission. It's not respiratory borne. Measles, on the other side, is we're still actively vaccinating against them and we're keeping it eliminated still because there is no asymptomatic transmission. What's wrong with COVID? How can we not do it? It's the same concept that comes over and over again. The issue is it's respiratory borne. It looks like any other cold and flu virus, right? So it's hard to differentiate what's COVID and what's not. And there is asymptomatic transmission. So we're not going to be able to eliminate it. We're not going to be able to eradicate it. The only way to do this is to control it. And that's what I'm going to leave Zainab at.
It's on me, right? We're going to control this with all the information we're giving right now. I did want to touch on the variants really quickly on the map. So currently we're kind of slowly getting less with the BA2. We're having a majority right now of BA 2.12.1. And that's about 60%. And then we're seeing starting to come in is BA.4 and BA.5. So those are coming in from South Africa as we're seeing this pattern continuing to emerge. So the variant, Omicron subvariant party is continuing. So what can we do to control the virus, right? The vaccine clearly was not a one-switch solution. And continuing vaccinations is also not a solution. So what can we do, right? So this is called the Swiss cheese respiratory pandemic defense model. And so you see here slices of Swiss cheese. Each of them is something that we can do, personally, or maybe as an organization, or as a society that can provide some layer of protection against a respiratory illness such as COVID-19. So that could be, staying home when you're sick. That could be wearing a mask. That can be getting tested, if you show symptoms or if you're exposed. Quarantining and isolation. Vaccines is obviously a key component. And you'll notice that all of these slices have holes, right? None of the factors or layers is completely foolproof, but when you layer them one after another, you'll see that there's some level of protection for this person that's on the right side. And this is especially important for people who may not have complete protection from a vaccine. Somebody who is a cancer patient, somebody who has a liver, lung transplant. They might be vulnerable to where they can't really be in society if they don't have all of these layers in place to protect them. So, next slide. So just to review some of the things that we talked about, we kind of did a SWOT analysis of seeing how we have done so far in the pandemic and what we can do to improve for the future. Okay, so some of the strengths that we had, the vaccine development was amazing. Now, how could we use that same level of focus and resource, allocation to, do something great like curing cancer, for example, right? We have the resources, we have the expertise in this nation, so we can use that focus for something similar in the future. And I wanted to acknowledge your contributions as healthcare workers, your incredible strength that we've had in the past 2 years, and we need to continue to bolster you all to make it a sustainable workforce that we can reach the next pandemic and have you all be protected and not get burnt out and overwhelmed. But we do have some weaknesses, that we need to address. And I find that a lot of those are kind of mindset shifts that we need to make, whether that's, thinking about individual risk and protection versus collective risk and protection. Thinking about the fact that when wearing a mask isn't just about protecting myself, but protecting somebody else. And then also reactive versus proactive approaches, putting in those prevention strategies before people are starting to get hospitalized. And then also short-term versus long-term thinking, right? We want to think long-term in terms of preventing long COVID and preventing future pandemics from getting as bad as COVID did. Another thing that we didn't get to talk about much in this presentation, but we saw just extreme health disparities in the mortality rates, hospitalizations from COVID, and that was because of existing disparities that exist in the United States. And a lot of that is based on resource, differences in access to healthcare. So improving our primary care access and chronic disease management can really go a long way to improving people's baseline health so that we're not as vulnerable to a future pandemic or the one that we're currently in. But we have so many opportunities. We had a rise of telemedicine, which really expanded access to things like mental health care for so many people. We have this mRNA technology that now we could use to develop so many different precision medicine tools. And we also, importantly, need to increase and continue our global collaboration for things like vaccine equity around the world. We need to improve our public health infrastructure, data systems, workforce. We really need to make sure that we have those testing, tracing, quarantining capabilities in place for a future pandemic. And also, I think one of the not benefits, but something that's really been made more aware across our society is the importance of mental health. Especially young kids, because of the disruption in their education, they faced a lot of mental health issues during the pandemic, as well as healthcare workers. So we really have an opportunity to bolster that mental health, take advantage of the fact that people are talking about it now, and really do something about it. And then finally, we've discussed these threats, misinformation, long-term effects of COVID, those continued mutations, they keep coming, and also new outbreaks, new pathogens, whether they're made from a lab or whether they're naturally occurring. These are all things that we need to be prepared for moving forward. So that's the SWOT analysis. I think we're ready for...
Thank you, Dr. Khadir, Zainab. We want to take an opportunity to hear from all of you. If you have questions for our panel, or if you have comments about something that was spoken about up here, I think we're gonna try to have you come up to the front. It'll just be a little bit faster to get.
Yeah, if you could just come up to myself or Alifia Bin, and we can get those questions.
Certain regions in the world who lack vaccinations are more prone to COVID infections. Why should that be so? Like Africa, Far East.
Sorry, one more.
It said, Why are some places more prone to COVID infections?
I'm not sure about why some places are more prone to COVID infections, but I think it's most likely depending on how you live. Like as I said, the transmission depends on three things, right? One is how much exposure you got and what was the length of exposure. So the close proximity, the closer you live with each other and all that kind of stuff, and the environment you live in is probably what makes it more prone to more infections than anywhere else, you know? I think that may be the reason. I'm not sure.
All right, well, thank you for that great review. It brought me back to, I did the height of COVID in New York City in March 2020, so that it really brought me back to that. But this is not a question, but rather a comment. I wanted to offer everyone the pediatric perspective. I think you guys did a great job of.
Omicron is so mild. This is so great. You know, it's so mild. But then when you look at the transmissibility, it was so high that a lot of our, kids that weren't vaccinated yet, the pediatric hospitalizations went up so high because the rate of transmission was so great, and we basically had no precautions taking place. So I agree. I think that's something that I wish we were talking about more here. Thanks for bringing that up.
Thank you. And for Khadir, right? So, we're all talking about the second booster now, and there are a lot of people getting the second boosters. One of the questions was like, is it reasonable to wait for the bivalent booster from Moderna, or should we be talking about that when we're talking to the patients?
So that's a good bivalent, meaning like flu and COVID vaccine together. Is that what you were referring to? Yeah. So as I showed you the slide, the last slide of the vaccine, it's 67% effective, but it wanes down in 6 months. The issue is, I think for time being, it is approved for people who are higher risk. But it will come in the future because people who have been vaccinated are already about a year out. So the people who had the first booster was, I remember mine was in October of last year. So my thought is that there will be a recommendation coming out soon that once the year hits, I think once a year will probably be available for everybody, and 6 months for people who are more higher risk. I think that's what's going to end up happening unless we're changing the vaccine and to a more the most variant that's going on right now, which is very plausible. Which we know that it takes about 1.5 years to just produce a vaccine now.
A question, Dr. Khadir. So what is the defining criteria for long COVID in adults? And again, disability was mentioned as it's so what are the requirements for that? That's my first question. And tagged with that is, so we are seeing long COVID from the Alpha and the Delta variants. What about the Omicron? Are we seeing any effects, and how would you comment on that, please?
So 2 questions. So first one, the criteria for long COVID is basically people who had COVID and they have these symptoms, chronic symptoms, which are just not going away since they had COVID. They did not have this before, but now they're lingering effects from it. The problem is we don't know much about it, unfortunately. There is the pathogenesis of the disease is not explaining the long COVID itself. It's I would compare this to kind of Lyme disease, where you have this post-Lyme syndrome. It's similar to that kind of effect. And I know we laugh at Lyme disease, but people who are affected by it are affected by it, right? So that's the issue. But we don't have a good pathophysiology behind that. But the definition of it is basically lingering effects from it after the exposure of COVID, and it's not going away. It is definitely positive it's definitely there with Alpha and Delta variant. The Omicron variant, I don't think the data is out there yet because it's just too early.
Can we have the COVID panelist back up on the stand, please? And we will continue that question and answer session.
तो अजय वैक्सीन इफेक्टिवनेस નું જે આપે સ્લાઇડ બતાવી in that it said કે the effectiveness goes down after x number of months. Is that clinical effectiveness or is it antibody effectiveness?
That was clinical effectiveness. Kemke, this is 2 million patients.
Okay.
Yeah, so it was clinical effectiveness.
But do we have any data whether if somebody had COVID versus having had the vaccine, is there a difference in what the rate would be at the same time frame? Is having COVID more effective in prevention future COVID?
So like you're asking, if you get COVID, is that better than getting vaccinated?
Correct.
I do not know the answer to that question.
Okay. But because if something is less virulent, like the B1 strain, is it better to get the COVID?
I get what you're saying, but the issue is that
we don't know.
The issue is long COVID too, right? So people who get breakthrough COVID is not spared from long COVID.
That's true. Thank you.
I have two comments from a hem-onc perspective. One is when you talk about the society cost, we forget what it did to the cost and the lives of the patients who were already having some disabling diseases like cancer. It was even true for other CHF and all those patients, particularly for cancer patients. Also, we were very afraid about what it would do for the screenings because we stopped screenings. And unfortunately, I'm sure in the next year or two, we will see that data, that how many more patients got more breast cancer, colon cancer, and so on. So that is one important thing. And as hem-onc, we were very proactive in telling our patients, please go. We were behind our hospital to start all this screening procedures. And that as a group of healthcare providers, I think it's very important to stay with the hospital and tell them, yes, we are facing a pandemic, but please let's not forget what is important to save lives, which we know we can. That's one. The second thing I wanted to point, I don't know if there is, any other hem-onc felt, initially we were very good, we were consultants, this was not our disease, we didn't care, and then we found the thrombosis and everybody was calling us and we didn't know what the hell we were dealing with. The other thing that came about, it not only an infection, which was very scary, was the vaccine-induced thrombotic thrombocytopenia. It happens rarely, but if anybody has seen this, it is the scariest thing because this was with patients who were otherwise asymptomatic, who did the right thing, went, got the vaccine, and now they were really facing a deadly illness that we didn't know anything about it. So that's something to keep in mind. If your patient got vaccinated, their platelets fell, you better call the hem-onc and get them started on something.
Thank you so much for bringing that up. And the excess death that's happened in COVID-19, not all of it is attributable to COVID, the disease, right? It's because of missed screenings. It's because of elected procedures that weren't able to be conducted. It's because of hospital beds that were full, right? So that excess mortality is something that we didn't even cover here. So thank you so much for bringing that up.
So this is kind of two separate questions. One for Dr. Khadir. you mentioned Paxlovid as kind of a post-exposure treatment. I know the U.S. government has invested a lot of money in it, and it's being pretty widely prescribed. But there's a thing coming out right now about Paxlovid rebound or breakthrough. Can you speak about that a bit, please?
So it's a rare thing, but it is there is data that it shows a rebound effect where what happens is you test negative after about 5 days or so of taking Paxlovid, and then you get between day 8 and 10, you get positive again and lasts for about 3 days. So, but does it make you more transmissible during that time? We don't know about that data yet. But yes, there is some, it is very rare so far, at least.
I just want to take this moment to thank Zainab Ben and her team that Mufaddal had mentioned about a document that SBMA had published to Jamaats across the USA about guidance on how to reopen masajid and majalis and mashahid at the time of COVID. And Zainab Ben and her team, which is I think Asma Ben Ghulam Hussain, and then Jamila Ben Raja, those all MPHs, right? They did the core of the work and created such a robust document with guidances on exactly how in the safest way ke muminin pachu majliso mahazir thai. And it really helped in Ramadan the year before last on how that we can safely open, and the statistics speak for themselves in the sense that we had very few cases of COVID during those times. So thank you for that.
So just to end on a positive note, I would like to give Dr. Khadir and Zainab a moment to just give some final thoughts.
So my last thoughts before I leave, this pandemic really shocked the medical and scientific society with its unique characteristics and brutal way of transmission, morbidity, and mortality. Yet, it did show the importance of robust science, innovative treatment measures at multiple levels, and the resilience and dedication of the frontline workers, medical and non-medical workers as well. But the one last thing I do want to mention is to get control of this disease, it has to be a global response. It's not going to work by just being America because there is no borders anymore.
First, I just wanted to say I'm very thankful for the opportunity for the Khidmat that was bestowed upon me. So just really grateful for this opportunity to help support your work. I wanted to just end by saying that we have tried and tested measures. Many countries learned from their past experiences with pandemics. So this is our opportunity to do the same. And this is personal for all of us, right? We have our kids. My daughter was born in January of 2020. So you can imagine, this has been her entire life. And so that really motivates me to say, well, what can we do for our kids to have a more pandemic resilient future? So I hope you'll take that and say, well, what can I do? Where can I contribute so that we have that to give to our kids moving forward? And again, very thankful, shukur guzar for the opportunity for Khidmat. And it's thanks to our trusted messenger, Sayyidina Mufaddal Saifuddin Mola, that we have been safe and protected throughout this pandemic. So, Kudrata Mola, Dola Amir Sharif ni Umar Sharif ne taroze kayamat dar azane daraz kare. Amin.
Dr. Khadir and Zainab, we want to thank you very much for all the time you've put in preparation. I know there were many conference calls late at night, so Appreciate all your work in preparing this.
Thank you, Dr. Mufaddal.
Thank you.
He
So-
made this happen.
That's
truly,
right.
So thank you, Dr. Mufaddal.
So, moving along, up next, we would like to thank one of our.
I propose that we all stand up and show gratitude to the healthcare workers who have helped us to achieve this fight against the pandemic.